Disc at L45 disc herniation with back pain and right-sided pain. And you're tired of suffering, right? He's talking to me from under the drape. So we do surgery with our patients awake. We are going to put our patient to sleep at some point, just not yet. And he has what's called discogenic pain, meaning pain from his herniated disc. Does the pain go down your right leg? How far down? All right. Is it always there or just sometimes? As soon as you stand up. All right. I'm just pushing around on your back, okay? So listen to me. We're going to get started. You're going to feel a little stick and burn. That's just putting some numbing medicine in, okay? You might feel a little pinch here or there. If it bothers you, say ouch. I'll give you some more medicine. The only thing I really don't want you to do is to try to move around and get off the table. I want you to lay still, okay? Now, if you feel the pain going down your leg, say ouch, down my leg. That way I know, okay? Otherwise, this will be over before you know it. All right, I'm just feeling around, and I'll be talking to our audience while we're doing this. We're doing 4-5, correct? All right, little stick and burn like I told you. Just relax, everything's okay. I will let you know if we have a problem, okay, sir? Okay. And you just tell me ouch when the pain is bad, and if it goes down your leg, say down my leg. So we gave 5 ml of numbing medicine. Let me know if it's bothering you.
It's bothering my left leg.
Well, we're not anywhere near your left leg. Well, you have a leg squeezer, right? It's down by your calf, correct?
Yeah, but it feels something different. That's a cramp or something.
You're getting a cramp? All right, what can we do to make it more comfortable? Let's get the nurse over here. Get under the drape. Because we haven't even started really yet. We just gave you some numbing medicine. Move his foot around and see if you can. He sounds like he's having a cramp in his left calf. Can you? Yeah. Let's turn off the leg squeezer. And go ahead and move his foot around to try to relieve the cramp. Do that now, please. Yeah, you need to move his foot. You know what happens when someone has a calf cramp, right? You got to bend your foot backwards. Is it still hurting? Are you doing that?
Yes.
Both feet? What are you doing with the foot?
I'm just flexing it this way.
Yeah. You got to go hard and far. Otherwise, you're not going to stop the cramp.
How's that?
Much better.
Let us know when it's better for you and we can relax. You just need to relax your body a little bit.
Is it better?
It's a
I
little
feel like
bit
I'm
hard.
pushing you out of the bed.
I understand. So our patient is having a cramp in his calf. And do you have a stent in?
Yeah, bilateral iliac.
I see it. Let me know when I can proceed, okay?
Okay, I think we're okay.
All right, just try to relax. Everything's going to be okay. Promise. We're going to get this done, and you're going to feel a whole lot better. Is your back pain all the time, every day? Shot? What, mostly leg? Let's go lateral. Looks like I may need to be a little bit lower. Go. So I'll be talking to the team, okay? And I'm going to be giving them orders, so you get to listen in. But don't worry, it's not for you, okay? That looks pretty good on the lateral view there, Jordan. But I need to figure out where we are. Shot. Uh-huh. That's good. Wonder if we could be a little bit lower. Are you comfortable? Uh-huh. Take. That's just my hand pushing on your back, all right? Take. Shot. 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 That's the facade. Let's go AP. See how medial we are. Are you better, sir, with your cramps? Yeah. You need us to stretch your feet some more? No, all right. Just try to relax your legs a little bit so you don't cramp up again. Uh-huh. All right. A little too posterior. Lateral. Shot real quick and then lateral. All right, go lateral. No, it looks like we're right near the graft, but we're not. The graft is very far to the front of his spine. We're in the back. Shot. So. Shot. Let me know if you're uncomfortable at all, okay? Again, I'm hitting facade. Shot. We're getting closer. Shot. That's just my hand back here, okay? I'm not getting fresh with you. Shot. 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 That bothering you? All right, I apologize. Shot. 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 That's better. Shot. We're pretty close to your herniation right now. Shot. Let's get an AP. So we're at the L45 disc. You can see. We'll just check the MRI one more time. Yes, I see it. And you can see the iliac crest, which look like a rainbow going right above where the tip of the probe is. And that's perfect. Let's go back to a lateral. And once again, the graph that you're seeing, it looks like a boomerang upside down. Not a boomerang, what are those things? Slingshots? Slingshots? Yes. And upside down. All right, you're doing fantastic. We're almost where we need to be to do your surgery, okay? Now, you said most of your problem is in your right leg?
All of it was right leg.
You never get back pain?
Rarely. If there was, it was like a 2 or 3. Not at all. Oh, yeah.
And is that where you get your back pain?
Yeah.
How bad is that on a scale of 1 to 10?
Ooh, that's 11.
11? That's L45. That's the bad disc. I realize you're young. That's going to get worse as you get older. So we're going to fix it for you. When you wake up, we'll be all done.
Okay. Yeah, the right foot's asleep now.
All right. Have a good sleep. Shot. Can you count out loud for me from 1 to 100? Shot.
Starting now.
Starting now. Count from 1 to 100.
2,
Shot.
3, 4, 5, 6, 7,
Keep going.
8, 9, 10, 11, 12,
You can see it, right?
14, 15, 16, 17, 18,
Shot.
19, 20, 21,
You're doing great.
22, 23, 24,
Shot.
25, 26, 27,
Shot.
28, 29, 30, 31, 32, 33, 34, 35, 36, 37.
If you make it to 100, we don't have to pay the anesthesiologist. Please count faster.
41,
He's like, should I count faster? Maybe that's not such a good idea since he's the one keeping me out of pain, right?
51,
You're doing great. Keep going.
53,
We made our incision.
54, 55, 56, 57,
All right, now in Latin.
59, 60, 61, 62,
Keep going.
64, 65, 66,
All right, relax. You're doing good.
68, 69, 70, 71,
All right, so at this point, we're inside the disc. We went through the foramen to get there. And we're doing an approach at about 45 degrees, you can see, to the spine. And our anesthesiologist is slowly putting the brain asleep. Lay still. Relax, you're doing fantastic. IV is good, working good. Just lay still. You're doing great. Keep counting. You can see the graft is in front of the spine. You all see that now with the view? Look to the left of the spine. You can see the graft. It's got little markers on it. Kind of show you where it is. And we want to stay away from that, obviously. Let me know when I'm ready to move forward. All right, shot. So as I'm advancing the dilator, I'm watching the guide wire, front of the guide wire. Shot. And I'm making sure we're not going any further in with the guide wire. Shot. Now I'm getting into the foramen and the back of the herniation right now. I can feel it. Yeah, right there. Shot. So I've advanced this dilator as much as I can with my fingers, and any more than this is unsafe. You want to use controlled bursts, which is what I'm going to do now. And I do that using a mallet. You have a question, Sean?
Yes. One of our viewers from Facebook is wondering, is L45 the most problematic disc?
Yes. Great question. Is L45 the most problematic disc? 100%. You are correct. And that's a known fact. I didn't just make it up. Everybody in spine surgery knows that. L45 is the most common disc to be problematic. And the reason is because of the curvature of the spine and the load. It's really, there's only one disc that carries more weight than that, and that would be L5S1. So it really sees the most weight and force, pressure in the entire lumbar spine. So that and then L5S1, those are the two that typically have problems. Lay still. You're doing really good. When you wake up, we'll be done. Sean? Shot. Shot. That's perfect. Good. So we're inside the disc, and as I've told you all before, the technique of starting inside the disc and working your way out, that is a technique I learned from Dr. Anthony Young out of Phoenix. And Dr. Young is an old Master Yoda type orthopedic surgeon that I have a lot of respect for. He's taught me more about spine surgery, honestly, than anyone else except for probably Jeff Henn, who trained at the Neurological Institute in Phoenix. And it's funny because Jeff Henn trained in the traditional types of spine surgery, and Dr. Young, Anthony Young, developed a new endoscopic types of surgery. So they're sort of at odds with each other, even though they're both in Phoenix, Arizona. One is an academic center, the Neurological Institute, the other private practice. They happen to both be next to each other. Jeff Henn really taught me the most about instrumentation and doing a lot of instrumented type surgeries, screws, rods, cages. And then Dr. Young taught me about the disc and taught me how to do transforaminal surgery. Unfortunately, Dr. Young is retired now, so he doesn't do surgery anymore. He just teaches. He's Chinese, so he goes to China and teaches the Chinese surgeons how to do endoscopic surgery. Unfortunately, the Chinese are getting ahead of the Americans on endoscopic surgery because the government promotes it. Here, the government doesn't promote good medical care. You see what happens in the VA system. Patients have to fight to get medical care that they need and deserve. And the government is always trying to save money. And the reason for that is not our government, folks. It's the insurance companies. They run the government programs. They have subsidiary companies that basically run the VA system. They run the Medicare system. It's all run by private insurance companies, which are all for profit. And they get paid money when they deny treatment to patients. The more money they save the government, the more money they make. They get about 30 cents on every dollar that they save the government. So if you're a VA patient trying to get your back fixed or your knee fixed, and you're wondering why it takes 6 months or a year on a waiting list, it's because the insurance companies like Blue Cross that run the VA system, they get paid for closing the operating rooms early every day and keeping you from getting an MRI, X-ray, CAT scan, some type of test that would help the doctors figure out what's wrong and what needs to be done to fix your pain. Unfortunately, that's the reality. How do I know? Because I worked in the VA hospital. For 7 years, I worked in the VA hospital. And I saw it firsthand. And I didn't understand it, and now I do. It's all about saving money. It's a shame because they don't tell these soldiers that are signing up to go fight for their country, they don't tell them, yeah, go out there and put your neck on the noose and your life on the line, and when you get back, we'll do everything we can to keep you from getting medical care you need. But that's exactly what they do. All right. Now, there are good people in the VA system, don't get me wrong. The VA has some very good people, but the ones who run it and manage it, and there's a lot of bad ones, and they're chosen because they want to ration care. That's really what's happening. It's rationing of care. So in China, they ration care too, but they do it smart. They avoid fusion surgeries. They don't pay excessive amounts of money for implants. They basically steal everyone's implant ideas and they manufacture those screws. Instead of costing them $800 for a screw, they cost them $2. And then there's no incentive for surgeons to use screws. Whereas in the United States, surgeons are incentivized to use screws and do fusions. In China, there's no incentive at all, but a lot of surgeons, there's no incentive but to provide great medical care, okay? And that's the truth. The surgeons are all competing with each other to be the best at minimally invasive surgery. So the newer technologies, the better technologies, like the Duke laser disc repair that you're watching right now, they want to learn this stuff so they don't have to use screws and rods. So the patients recover quickly. But in the United States, you have special interest groups like implant companies, Medtronic, DePuy, Alphatec, Nuvasive. They're all selling their implants, so they want patients with getting spine surgery to get implants. And the hospitals make more money with those surgeries, so they're happy to do them and promote them. But in China, this type of surgery is what they're starting to do. And unfortunately, I'm one of the only in the United States doing transforaminal endoscopic surgery. And I've been doing this surgery 15 years. Why? Because it's great surgery. It works.
The question.
Yeah.
Our viewer on our Facebook is wondering what keeps the disc from re-herniating after you move the herniation with the laser.
Yeah. What keeps the disc from re-herniating? Great question. The patient doing what they're supposed to do. It's called restrictions. Everybody that has surgery has restrictions. And whether you're having your gallbladder surgery or you're having, spine surgery or brain surgery, it doesn't matter. Everyone has restrictions. If you don't follow the restrictions, you can injure the part of your body that the surgeon just fixed. So with this particular surgery, the restrictions are no lifting more than 25 pounds for 6 weeks. And then it goes to 40 pounds for the rest of the year. Also, no bending over to pick things up from the ground. So those are the two restrictions. That's how patients avoid re-injuring their disc. It's all about following instructions. I hope that answers the question. So what happens then is the disc will heal itself. After 1 year, it'll be completely healed. The annulus that I'm debriding will reseal on its own. And I'm developing a treatment that will help it reseal even faster. So you won't have to wait a whole year. Don't ask what the treatment is. Because I won't tell you. Not yet. Not yet. Someday, soon. Someday the cat will come out of the bag. Look at that piece of herniation right there. That is not a nice piece of herniation. So I remember when I put the tube in, I kind of went through the herniation and shoved it back into the disc. So that way I can take it out right here inside the disc. Looks like a big piece right there. Yeah. Oh yeah, baby. Oh yeah. How do you like them apples? All right. Take. Wait. So I'm just gradually removing the tube from the disc. Just backing it out. As I do that, I can see the tear. You see all that right there? That's herniated nucleus attached to the annular tear, annular fiber. Those are annular fibers, and that's the nucleus. So it got stuck in there, kind of like if somebody threw an egg in your hair. You got to go and try to wash it out, but can't wash this out because there's no way to shower your disc. So there's a piece of herniation right there. You see that? And it's literally caused inflammation inside this disc that caused the inflammation, then caused the herniation to stick to the annular fibers. Yeah. It doesn't want to come out. So I have to zap it some more. Any questions? The last two patients are doing great. The posterior cervical laminectomy infusion from this morning is ready to go home. I just have to go out there and set her free. I wanted to do a video of her. I think she'll let us. She's doing really good. She was a little bit nauseated, but I think she got some Zofran. That's probably from the anesthesia, right?
Program only lasts really 2 or 3 hours, so she was kind of, her first trip from the OR was where I'm at from now.
All right. So we're going to send 2 patients home in a few minutes, and then this patient will take about 30 minutes to an hour to recover and go home. You're watching an outpatient spine surgery. It's done here only at Duke Spine Institute, and these patients have on average 95% elimination or curing of their back pain and 95% elimination of their leg pain long term. So I've submitted a paper to the International Society for the Advancement of Spine Surgery, ISASS. They have a meeting coming up in Miami, and I'll be, hopefully if it's accepted, I'll be presenting our long-term outcome data to the group of spine surgeons there. Now here's the end right there of the tear. You can just see how grungy it is. None of this is normal. And you can see how the blue stuff, the herniation, is just sitting inside the annulus, and all this yellow goldish stuff that you see coming up, that is the calcification, dystrophic calcification. See that? So as inflammation progresses over time and becomes chronic for months and years, it causes ingrowth of calcium basically into the tissue. And the pathologists call that dystrophic, like dystrophy, dystrophic calcification. And it's an indication of pathological changes to the tissue, where the normal architecture, normal physiology of the tissue has been disrupted. And there's calcium that comes in and binds to those abnormal fibers, connective tissue fibers, etc. I think we're overexposed. Let's turn down the light just one click. Thanks. I think that's good. You just need about 3 minutes left, doctor, if you want to start planning. There it is. There's the blue herniation stuck in the annular tear. Let's see how long this will take me to get this out. Probably another 3 or 4 minutes. This is the annular debridement that's characteristic of the Duke laser disc repair. Duke laser disc repair is unique. There's no other surgery in the world that does an annular debridement. There's discectomies, there's laminectomies, there's foraminotomies, there's fusions and artificial discs, but this is the only surgery where the annular tear is debrided. And because of that, the patient's able to eliminate their back and leg pain. And we do this without removing any bone out of the spine. Microdiscectomies, laminectomies all require the removal of bone, which damages the spine. That's pure and simple. There's no way around it. It's damage to the spine by doing the actual surgery itself. You're not helping by removing the lamina. You're not helping the patient by removing the facet joint. You're hurting the patient. Those are normal structures. They should not be messed with. Yet, for many years, 100 years, that's all we had. Look at that granulation tissue right there. The pinkness of it. That's all has like little capillaries. Look at that herniation right there. That has capillaries in it. It's, you see, when you get granulation tissue, it's tissue of healing. And it has little nerve fibers that are very sensitive. And they hurt. Like an example of granulation tissue is a pimple. You know, it's the actual granulation tissue and small nerve fibers inside the pimple that cause it to be so tender. Imagine a pimple on the back of your disc. Every time you bend, twist, stand, carry, you're putting pressure on that pimple. And it's actually a lot bigger than a normal pimple. So imagine putting pressure on a couple of big pimples. Why is water... Gosh, you didn't do my wrist? Luis.
Yes.
I am not feeling the love today. I am not feeling the love. Need I say more? All right. You don't like my shoes, do you?
I love your shoes.
No, you don't. If you love my shoes, you wouldn't be trying to clean them with this water.
We have a question.
We have a question. You've got to raise your mic volume, otherwise we can't hear you.
Is this a bit better?
That's a little bit better. You need to go louder.
Okay, how about now?
That's okay.
Okay, the viewer from Facebook is wondering, are you able to remove all of the hernia material? And if not, what percentage can you remove?
So great question. Am I able to remove all of the herniated material? And if not, what percentage? I'm removing all the herniated material that's causing the patient to have symptoms. So if you asked what percentage of the symptomatic herniated material I'm removing 100%. If you ask what percentage of the structural herniated material I'm removing, I'm probably removing somewhere around 50%. Okay? So the next obvious question is, how do you tell the painful herniated material versus the non-painful? And that is experience, my friend. You have to know right where to go. I need 30 seconds and we're done. Is the irrigation out?
Yes, sir.
Huh?
Yes, sir.
It's out or still there?
No, it's still running. I thought
Okay.
you said it's not. It's on.
Thank you. 10 seconds. Oh, we just got another reverse herniation there, so this is all partially calcified stuff. How's he doing? Good? All right, just about done here.
It wasn't like you pushing on the pimple.
It was, right?
It wasn't like it.
It was or wasn't?
He wasn't. Yeah, he could tell. He could tell you were down there where his pain is.
Yeah. It's localized because somatotopic organization within the cortex. I'm done. Let's look and see. Looks good. Let's go look at the nerve root. Maybe we'll just see this one. This will be the L4 root. There, can't really see it that well. Let me see the laser. It's just buried in fat. I'm not going to take the fat out. You won't like this. All right, that's it.
Lights on, please.
Well, if you haven't downloaded the Duke Spine Institute app, you can do it on your app store. It's free. We don't charge. Lay still. And if you'd like to join the Spine Surgery Support Group on Facebook, Spine Surgery Support Group, that is the Duke Spine Support Group for anybody with back and neck problems. We answer questions for free. No charge. All right, so
Thank you.
You're cold? Oh, you're out cold, yes. You told us all your secrets, by the way.
Well, it's not much. I've got most of them.
I'm just kidding. You didn't really say anything. But everything went good. You were done. I think you're going to be real happy once you're all healed up, okay? So for those of you watching, that's the incision, 7 millimeters. Give it another minute or two. And it's just a Band-Aid. And the herniation is gone. The patient, we haven't taken any bone out of his spine, out of his facet joint. Anywhere else you go when they do a microdiscectomy, the surgeon is taking normal bone and joint out of your spine just to get to the herniation. It's insane. Now that I've been doing it this way for years, I stopped doing microdiscectomy. I won't even do it because it's so damaging. It's so much worse than the Duke laser disc repair. And honestly, surgeons that don't know how to do this surgery, they shouldn't be doing disc surgery at all. They should be referring to centers that are more advanced, like Duke Spine Institute. Sorry, but it's the truth. EBL, 2 mil. That was the right side. L4, 5. Okay, folks, nice job. I'm going to go check on the post-ops and send some people home. All right, if you have any more questions, feel free to type them up right now. Sean, do you have any more questions?
None currently, no.
The audience knows everything, huh? All right. Hope you enjoyed. Dr. Duke Majan, over and out. Type up those questions, and I'll answer them for you in a minute.
All right, for those of you still watching, we have Dr. Duke in the room. He's just going to wrap up the last surgery you saw really quick, and we'll call it a night. If you do have any questions remaining, please post them in the chat.
Okay, everyone. January 14, 2021, 4 surgeries done. The first one was a bilateral carpal tunnel release. We don't normally do bilateral. We did not broadcast that one. And the patient went home very happy. The second case was the posterior cervical laminectomy infusion. And she went home doing great. She's a little bit nauseated, but that's just from the anesthesia wearing off. It takes usually a day to get over all the anesthesia. But other than that, she did perfect. We did 2 Duke laser disc repairs, one L45, L5S1, left side. I just saw that guy and we just did a video on him. He said his pain is gone in his back and down his left leg. So he's very happy, already cured. And then the last laser surgery is waking up and he's doing fantastic. So that's it for today. We've answered all the questions. I hope you've enjoyed watching the surgeries. And, we'll see you next week on Tuesday. We have 4 more